Welcome to our webinar, New Ideas to Crush Costs in Your Supply Chain. My name is Misty Eicher, and I'm the Enterprise Corporate Accounts Director of Finance for the South and West regions at Cardinal Health. We at Cardinal Health understand that the change in the healthcare industry is unprecedented. Reimbursement models are shifting from fee-for-service volume-based care to outcomes-driven value-based care. Care is becoming increasingly patient-centric versus health system-centric, and the population is living longer, many with complex diseases. In fact, those are just some of the many challenges taking place that are pulling healthcare providers into uncharted territory. You can see that there are many trends impacting the healthcare landscape. I'll just comment on a few. Through all of this, pricing pressure is increasing across the industry, and the need to control costs has never been more critical. Also, technology and data play an ever-increasing role in helping providers to address the challenges being faced. With all of this change, we know health system leaders must focus on improving financial performance, advancing the safety and quality of patient care, and staying ahead of healthcare reform. As cost pressures increase and reimbursement models change, we need to think outside the box and look for savings in different business areas, like supply chain. So I'm excited to be presenting today on the topic of crushing costs within your own supply chain. Let me briefly share a bit about Cardinal Health. As one of the largest healthcare supply chains in North America, we are essential to care, helping our customers focus on patient care while reducing costs, enhancing efficiency, and improving quality. In fact, 78% of hospitals in the United States use our products and services. We have deep expertise in supply chain and have a strong culture of Lean Six Sigma. We've been recognized by Gartner as leaders in supply chain innovation for the past 5 consecutive years. Supply chain doesn't stop at the hospital dock. Instead, this continuum leads us all the way to the point of use within the hospital to the patient. We continue to challenge ourselves to innovate and create value, something that all of us in the industry must be doing in today's dynamic healthcare environment. The Healthcare Financial Management Association Value Project was created in conjunction with 17 hospitals from across the country. The Healthcare Financial Management Association, or HFMA, has defined the value equation as quality over payment. Quality is the composite of patient outcomes, safety, and patient satisfaction. Payment is the amount paid by all purchasers of care, or in other words, cost. To improve the value equation, we all know we must increase quality and reduce costs. This will become increasingly more critical as our payment models transform along the continuum, away from the activity-driven fee-for-service reimbursement models and towards more value-based care and bundled payment models. I submit to you that supply chain should not be exempt from this higher standard and must also contribute to improving the value equation. It's too significant to be left out of scope. We need to raise our expectations of supply chain and find solutions to improve both quality and our cost position. The supply chain function in our hospital systems influence financial performance, and not only the materials costs, but also labor costs. The supply chain design impacts clinical workflow and labor costs, as well as materials management workflow and labor costs. The supply chain function in our hospital systems also influence safety and quality of patient care, as patient safety is impacted by the competence of our supply chain in managing product used on patients and avoiding use of recall or expired product. Supply chain processes also impact the amount of time clinicians have to spend with patients, which can influence quality of care and patient satisfaction. And there are healthcare reform implications, such as the FDA's unique device identification rule, which we will discuss later. With this in mind, today we'll seek to learn from supply chain models in other industries and discuss ways to reduce waste in your supply chain. We will learn from supply chain best practices in other industries and learn to reduce waste in medical device supply chain, enable your clinicians to spend more time in patient care, improve patient charge capture, and optimize the use of automation in your supply chain. We'll start with a look at some other industries. My daughter recently had her 6th birthday. One of the items on her wish list was a transformer, not the electrical kind, but the robots that transform into vehicles and back and into awesome robots fighting crime. Her big brother, who was 8, decided he would get this for her. He went to the store, found the toy section, and found the best transformer that would fit his little sister. I was really impressed with his thought process. He checked what it transformed into. She wanted a car transformer, not a truck, and then he checked the number of steps. He didn't want it to be too hard for her. So he found one with 8 steps for ages 6 through 8, transforming into a car. It was perfect. He then paid with his own money, proudly giving the clerk $11 in cash and asking for the change. Now let's look at what happened when my son bought the transformer for his sister. At the checkout counter, he started a chain of data that linked the transformer he just purchased back to the distributor, and then all the way back to the manufacturer. Then that data likely went to a company that monitors consumer purchasing behavior, such as Nielsen. The result is total upstream visibility of the transformer, from the manufacturer's facility to the point of sale and into my son's hand. The manufacturer has detailed information on consumer demand, making demand planning more accurate. And the manufacturer can set production quotas based on real-world data and make just the right amount of transformers to meet consumer demand. I know of a gentleman who works at a distribution center for a national toy store. During the holiday season, he's working 11 to 12 hours a day and weekends because it's their busiest time of year. Given how critical holiday earnings are to this industry, just think of how detrimental it would be if their supply chain failed. They would not have enough product to meet demand, and they would not hit their revenue numbers for the year. But it doesn't fail. It works pretty flawlessly. Trucks come in and come out all day long, and it's smooth and efficient because of the data. Stocking reflects seasonality based on data and analytics, so regardless of the time of year, my son is able to buy a transformer for his sister. In healthcare, we certainly have seasonality, whether truly driven by seasons, such as flu-related conditions, or driven by other factors, such as elective surgeries when out-of-pocket maximums have been met, or using up flex spending dollars at year-end. In this retail supply chain model just discussed, there's far less waste and inefficiency, and far less need to overstock and hoard products. The data tells the manufacturer and retailer exactly how to right-size inventory levels. In a nutshell, the data makes it possible to have a more efficient supply chain. The retail industry can do this for an $11 transformer. Can the healthcare industry do this for medical devices and implantables that can cost many thousands of dollars more? No, not yet. When it comes to a $6,000 medical device, there is no data capture and connectivity from the point of care back to the manufacturer. No upstream visibility, and no real-world data analytics that can help us understand demand planning. Instead, there are a variety of inventory models that may be used within the same hospital for many different products. So it's challenging at best to get an accurate accounting of products on hand, and difficult to understand where they are, who owns them, and when they're being consumed. The annual waste for higher value medical devices alone is over $5 billion. Much of this waste is due to poor inventory management practices, and that doesn't include the hidden value lost due to misaligned labor, product recalls, and non-compliance. Who pays for this waste? We all do. Manufacturers, providers, payers, and ultimately our patients. This is contributing to a higher payment side of the value equation. $5 billion. Imagine the impact to our industry if we would fix this. While the retail industry today is far ahead of us in managing the supply chain, there are some positive developments that we can rally around as an industry. As mentioned earlier, healthcare reform even impacts supply chain. For medical devices such as pacemakers, stents, and joints, the US FDA released the Unique Device Identification, or UDI, rule in late 2013 and recently issued their final ruling in October 2015. This does establish a process for a common worldwide system of product identification that will be applied to all medical devices placed into the US market. The rule requires manufacturers to assign a unique device identifier, or UDI, number to each version or model of a device. As part of the UDI system, the FDA is also creating a database, the Global Unique Device Identification Database, which will include standard data elements for each device with a UDI. And more good news. There are GS1 global standards that meet the UDI criteria that have already been in use by leading healthcare manufacturers. GS1 is a nonprofit organization with 111 members worldwide. They develop and maintain the most widely used supply chain standards in the world across many industries. The UPC code scanned at the checkout counter when you purchase groceries should be a familiar example. According to a McKinsey report titled Strength in Numbers, global standards could reduce healthcare costs worldwide by $40 to $100 billion, including savings of $30 billion to $42 billion from improved inventory management alone, reducing financing, processing costs, and obsolescence. By having a standardized GS1 code, you would be providing a great deal more time for clinicians to focus on their patients. One GS1 case study resulted in a 30% reduction in days payable outstanding, a 73% reduction in ordering discrepancies, fewer calls to customer service, and fewer stockouts as a result of nurses being able to scan barcodes at the bedside. A joint effort is needed to align to GS1 standards. Distributors, providers, group purchasing organizations, and manufacturers must come together to formalize the standard. With increasing government scrutiny under the Unique Device Identification Law, it is expected that hospitals will soon need to have more advanced tracking of medical devices used on patients. This will be nearly impossible without a strong industry standard. So we're moving in the right direction, but have a long way to go. Healthcare is fragmented, and it needs to be unified. I'm sure you have all seen a tag like this. This is not just a useless tag that retailers sew into clothing to annoy us. It is actually how they are right-sizing their inventory, reducing safety stock quantities, and all in all, saving lots of money. These tags are known as radio frequency identification tags, or RFID tags for short. These tags allow retailers to accurately count their inventory while greatly reducing the time spent counting the product. According to a 2010 University of Arkansas study, apparel retailers are achieving inventory accuracy of over 95% thanks to standards-based RFID tags on each item, compared to an industry average of 62% without tags. This technology saves huge amounts of time for each cycle count. We'll talk more about RFID later on in the presentation. If we're not using this type of technology, what are we using? Healthcare is the last industry that still uses the PAR system for inventory tracking. PAR stands for Periodic Automatic Replenishment. The problem with PAR is that it's guesswork. You look at your shelf and see what you have to replenish. You can set inventory levels and reorder points based on usage, but as soon as you do, they're almost immediately out of date. PAR is not automatically updated based on real demand, which means you are always counting, and it doesn't take into account sources of variation. It's very difficult to maintain the right inventory levels under the PAR method. You end up with stockouts on certain products in high demand, which leads to hoarding and increased amounts of write-off for expired product. On the other products, you replenish more than you need, taking up too much space and leading to obsolescence. My friend in Ohio used to own a small bookstore, and she used a replenishment model. Once a customer purchased an item, she would pull off the barcode sticker at the checkout and use that to reorder. For the most part, that worked pretty well. But the problem with this was that occasionally she would reorder something that had been sitting on the shelf for a couple of years. She was ordering based on PAR replenishment instead of demand. The second to last industry to use the PAR method was the grocery industry. They moved away from this years ago, when they adopted the Universal Product Code, or UPC, in 1973. Once this GS1 standard was adopted as the industry standard, it saved the grocery industry hundreds of millions of dollars. The UPC ensures standard data and barcodes on every product that are universally read by all steps of the process. We still need to implement a standard data platform in healthcare, and as previously mentioned, we encourage the use of GS1 global standards. There will be significant benefit if, as an industry, we move to one common platform versus maintaining multiple platforms. We've learned that other industries have realized significant efficiency and quality gains through improvements in technology and standardization in supply chain. It is clear that we need to raise our expectations regarding supply chain performance in healthcare. What should your expectation be of your supply chain? Improving quality and reducing costs. A process that allows clinicians more time to spend on direct patient care, not on supply chain activities. No expired or recalled product on your shelves. The ability to quickly and accurately identify patients impacted by recalls, for example, medical devices such as implantables. Standardization for the right product at the right price point and the right place at the right time. Complete visibility of inventory throughout your system. Informed, cost-effective decision-making. Lean processes, and effective use of data and analytics, providing demand planning and identifying opportunities for savings. Here's a question to think about. What percentage of time are your nurses spending on supply chain activities, such as searching for a product? 30%. Are you surprised? How could you improve labor cost efficiencies if your nurses spent 30% more time taking care of patients? For example, in many hospitals, a nurse is required to pull products from a closed cabinet system. Think of this like a cross between your ATM and a vending machine. The nurse walks over to an electronically locked cabinet. They have to sign in, find the product they want by typing or scrolling through some screens. Then they select the product, they type in the patient ID and attach the product to that patient. It takes anywhere from 55 to 75 seconds to perform this function. And then the nurse may have to go through the same process to put unused product back into the closed cabinet. Nurses are doing this 80 to 100 times a shift, and it takes up time. There's a national nursing initiative called TCAB, or Transitioning Care at the Patient Bedside. The goal is to increase nursing time spent on direct patient care. This should assist in quality outcomes and patient satisfaction. We already know that there is a correlation between nursing time with the patient and the likelihood for readmission. We also know that readmission within 30 days for the same condition is a sentinel event. I would rather have nurses ensuring patients understand how to take their meds or apply their dressings correctly than have them hunting for or managing supplies. Now think for a minute about your HCAHPS scores. The vast majority of the 32-question HCAHPS survey addresses nursing care. For example, in a section about nurses, the survey asks, during this hospital stay, after you pressed the call button, how often did you get help as soon as you wanted it? HCAHPS scores have a direct correlation on your revenue under the Affordable Care Act. The patient experience of care is a significant factor in the hospital value-based purchasing program, making up to 25 to 30% of your total performance score through 2016. Under this program, hospitals can either lose or gain up to 1.5% of their Medicare payments in 2015. CMS will up the ante over the next few years, with 2% of reimbursement dollars ultimately being at risk by 2017. With a growing amount of revenue at stake, hospitals must be looking for strategies to improve the patient experience and boost their HCAHPS scores. In Cardinal Health's view, supply chain processes should contribute here, freeing clinicians up from supply chain activity and optimizing clinical workflow. Advancing safety and quality of patient care is everyone's responsibility, and we should have the highest expectations of quality in this area. According to the FDA, in 2012, there were nearly 1,200 product recalls. This is more than double the amount of recalls from 2003, and many of these were serious. Think about the ramifications if a recalled product was used on a patient after the recall, or if you were unable to accurately identify recalled medical devices already used on patients. The cost to a hospital if anything serious happened would be enormous. The ECRI Institute named product recalls as a top 10 technology hazard. In your hospital, you must be asking your supply chain staff if they have the ability to accurately track and trace what products are used in a patient. This track and trace ability should include tracking of lot numbers and expiration, especially in highly sensitive products with the most direct patient impact. Additionally, it's estimated that up to 10% of medical device products on your shelf will expire. While medical devices make up approximately 20% of the volume, they make up about 80% of the spend on medical supplies. What if you could have that savings back? Generally, the purchasing and contracting departments have done a good job of driving down the cost of commodity items and distribution fees. They are good at driving down the price at the pump. While it's always a good idea to do benchmarking and stay vigilant in this area, in many cases we are reaching the point of diminishing returns. The focus needs to be on the hidden costs remaining. In particular, freight should be an area continually scrutinized. This is a picture of my kitchen. My husband is very handy and he's also very frugal. Last year he remodeled our kitchen. We ordered the cabinets and then had them custom stained. And when ordering our cabinets, he asked for a detailed breakout of the components. This turned out to be a great money-saving move for us. While we got decent pricing on the cabinets themselves, the side panel that we needed to create an alcove for our fridge, the one that's circled there, it was going to cost $400. This was basically just a sheet of plywood with nothing else special being done to it. The quoted price included the cost of the plywood plus an embedded markup from the cabinet company for handling and freight. Well, my husband knows the cost of plywood, and he went to the local lumber company and bought the same thing for $40, saving us 90% of the quoted price for those components. One word of caution in this area: be careful with your T's and C's. You don't want to lower your freight costs only to have the vendors shift the cost burden to handling fees instead. In the same way as we almost overpaid for that side panel, many hospital systems are paying much more for freight than necessary, especially for products not delivered through your distribution relationship. The freight cost may be embedded in the price paid for the goods, just like that piece of plywood. The best practice is to get the freight cost quoted separately from the price of the product versus getting a delivered cost quote. This will allow you to compare prices among different manufacturers on a comparable basis. Comparing a delivered cost to a unit cost without the cost of the freight could lead to the wrong decision. You'll also identify opportunities for savings on freight that may currently be hidden. If the freight costs are too high, you can choose to take responsibility for those freight costs by utilizing your freight program with rates that leverage your scale. In our case, my husband didn't mind paying for the gas to pick up our product at the lumber store, as it was much less expensive than paying a $390 markup on that piece of plywood. Standardization is also important to talk about. We've made a lot of progress in physician preference items. And just a few years ago, a drug-eluting stent cost $3,000, and now it costs somewhere around $1,200. However, physician preference items overall still have opportunity in the area of price point and standardization. With increasing physician alignment with hospital systems and pressure on costs, these areas need to be challenged as well. Hospitals should especially consider product categories where there has been relatively low innovation, yet price point has remained high, such as orthopedics. I had the privilege to be part of a medical mission to Peru a couple of years ago. We took a team of 2 orthopedic surgeons, 2 anesthesiologists, and clinical nursing staff to a well-respected clinic tucked away in a small village in the high Andes Mountains of Peru. It was a great experience and eye-opening in many ways. The people of the community were hardworking folks who lived off the land, and they were very appreciative of our help. As a part of this experience, I did get some more exposure to orthopedics. I mentioned earlier that my husband is very handy, and he has a lot of great tools. I have been a bit surprised to learn that many of the orthopedics tools bear a great resemblance to screws and drill bits that he might pick up at a Lowe's or a Home Depot. While obviously there are significant differences when it comes to material used inside the body versus in my house, it's still worth asking the question and challenging ourselves. In today's market environment, are we paying the right price point for these items? Are the expensive sales rep models sustainable? Or should we also demand greater value in these areas that historically may not have been challenged? Consignment is an important topic. This is an area with big spend, but historically low visibility and tracking. There are some inherent inefficiencies with consigned items. The delivery system for much of the consigned population is the trunk stock method. It's a very expensive delivery method with poor inventory management controls and high levels of expiration and obsolescence. The cost of all of those failures are reflected in the price we pay, just like shoplifting is reflected in the retail price. It's also a bit interesting that some of the most expensive and sensitive healthcare devices are somewhere between the kids' bikes and the lawnmower. Does your system have the right visibility to make the best decisions in this area? We cannot allow the inefficiencies to remain in the consignment supply chain. The UDI law mentioned earlier requires manufacturers to have unique track and trace capability at each level for Class 1, 2, and 3 devices as it rolls out over the next few years. This includes lot tracking and expiration information. With the upstream end of the supply chain complying with these new regulations, we should take advantage of the technology available and change how we purchase and manage devices requiring control, track, and trace. One Midwestern hospital that we've been working with recently moved away from their consigned model. They are no longer allowing manufacturer product sales representatives into their hospital, and they're seeing savings as a result. There are also benefits to be gained from process improvement and proper deployment of technology to prevent some of these common pitfalls in supply chain that we'll discuss. Overstocking. It ties up your funds and your space. Bulk buys should be supported by data and analytics. Otherwise, you can exacerbate overstocking issues and lead to increased obsolete and expired expense. First in, first out product usage is not being followed. Products are sitting on the shelf for long periods of time and becoming expired. Inefficient work practices. Manual cycle counting wastes time and creates errors. Have you ever looked at your perpetual inventory report and noticed a 6-digit figure for the quantity on hand due to the serial numbers being keyed in the wrong field? Counting typically adds even more errors. It's a long process, and people are prone to make mistakes or take shortcuts. Poor charge capture. This means lost revenue. Even as we are moving towards more value-based reimbursement models, much of our revenue is still tied to fee-for-service. Every year, healthcare providers lose more than $1.8 billion to revenue leakage, an average of 7% for every facility. A leading cause is inaccurate charge capture. Think about a clinician's job. They need to be manually tracking every product used on a patient. This is most prevalent during surgeries and procedures where the most expensive items are used. Without a point-of-care tracking system, items are going to get missed, which leads to this revenue leakage. So what's the bottom line? We need better data management and informed decision-making to facilitate an effective supply chain. The gift shop in your hospital likely has a sophisticated point-of-use data collection system. They know if your patients are more likely to purchase Snickers or Three Musketeers. Isn't it funny that their systems can predict patient demand patterns more accurately than most hospital inventory management systems? To summarize, there are a lot of opportunities to reduce costs in your supply chain. We need to raise our expectations. Next, we'll talk about ways to start making changes. We've learned how other industries have gained efficiencies in supply chain. We've discussed specific opportunities for improvement within the medical device supply chain. Now we'll look at pursuing best practices, the path forward. As a reminder, we need to pull costs out of the supply chain in total, not just move the bubble in the balloon. Our pain points in the industry can be addressed. Manufacturers have inventory management issues, and hospitals all across their IDNs do as well. Many issues are common to both manufacturers and hospitals, including product expiration, shipping costs, overstocking, consignment, and stockouts. What if we had a common strategy for solving our common problems? A new way to generate value by extracting the inefficiencies that manufacturers and hospitals share. This is not a game of shifting costs from one place to another. This is about creating genuine cost reduction that would directly benefit everyone, ultimately our patients. And it should reduce the payment side of the HFMA value equation mentioned earlier. So everyone should win. A number of years ago, I went to a national tax preparer to complete my tax returns. On one of my schedules, interest income that was less than $10 was reported. Ironically, as I scanned the itemized list of charges from the tax preparer, I saw that I had been charged a fee of $12.50 to complete the additional schedule that reported my $10 of interest income. Do you have low-value items such as gauze and Band-Aids behind expensive closed cabinetry? Is it possible that you are giving away your pricing savings by paying expensive automation fees to store those commodity products that far exceed the value of those products? Kind of like me paying the $12.50 to report my $10 in interest. This would be overinvesting in your automation. On the flip side, do you have expensive stents and pacemakers that are not appropriately secured or tracked in your supply chain? It is important to match the investment in supply chain automation to meet your needs without underinvesting or overinvesting. You should match the level of investment in process and technology with the value and sensitivity of the products. Investing in a single one-size-fits-all solution for all of your products does not provide the best ROI. So what are the best ways to manage inventory better and right-size your investment? Every hospital is different. There's no one-size-fits-all solution to fill the gaps in every supply chain. There are many different methods and technologies that have proven to be successful, though, in automating and simplifying inventory management practices within the provider space. RFID technology and two-bin kanban methodology are two methods that we have seen to be successful for managing low-cost commodities to high-cost devices or implantables. Both practices have the capabilities to capture data through a cloud-based management automated system, which enables you to track trends and make fact-based inventory decisions. Let's take a closer look at these two methods. The automotive industry first learned the two-bin kanban method from Toyota in the 1980s and quickly adopted it, replacing those expensive, labor-intensive, and inaccurate PAR methods. Toyota is one of the finest supply chain companies in the world and has been using the same kanban principle since the 1950s. Why? Because kanban is accurate, adaptable, and inexpensive. Two-bin kanban is best used to manage commodity and lower-cost products. The process is simple. The stock room contains 2 full bins for each commodity item, for example, bandages. The bins are tagged with a unique barcode for bandages. Both full bins are placed on the shelf, one bin in front of the other. Once the front bin is empty, it's taken from the shelf and placed in an empty bin area, and the full bin of bandages is just pulled forward on the shelf. Employees reorder the product by scanning the barcodes in all empty bins at the end of the day. The idea is that the first bin will be replenished before the second bin has been depleted. For the nurses, it's great. When they need product, they just pull it from the bin. They don't need to sign into a platform to record the quantity taken or returned. And through data analytics, the system should know how many to reorder to fill each bin, adjusting the amount contained in each bin based on real-time demand patterns. So nursing time is freed up to spend time with patients, and cycle counting is completely eliminated. We've seen the success of tube and kanban at Bellevue Medical Center in Omaha. They had a stable supply chain. However, they are always looking to improve and realized that there was opportunity to drive improvement in the management of their commodity supplies. Clinicians were conducting multiple supply chain activities to ensure that they had the right products at the right time. Clinicians at Bellevue would need to check out supplies from cabinets to ensure compliancy reporting was accurate, as well as other activities that took their time away from patients. Clinicians were performing a lot of non-value-added work. They made the decision to implement a tube and kanban solution, supported by a strong data analytics platform. After the tube and kanban solution was installed, the clinical staff could just enter the supply room and pull the product needed directly from the bin. They no longer had to log in and check out supplies from cabinets, and returning unused product was just as simple. No compliancy measurement needed any longer. And the materials management staff no longer needs to perform any manual cycle counts of products. This function has been eliminated. At Bellevue Medical Center, they reduced clinical time in supply rooms by 80%, along with a sustained inventory reduction of 35% and the elimination of cycle counting. The solution was so well received by the clinical staff that the Director of Materials Management at Bellevue said, if we had attempted to go back to the old model, we would have a riot on our hands. Let's talk about RFID. As mentioned in the apparel example earlier in the presentation, RFID stands for Radio Frequency Identification. Its electronically stored product information is transferred wirelessly from a tag on an item into a cloud-based management system. This information can include specific lot and expiration information unique to each item. In order to use RFID technology in inventory management, RFID tags are fitted onto the packaging of items. Employees can read and record product information through the wave of an RFID tag reading wand over a drawer of a product, or RFID tag reading cabinets can be installed to read product information in real time as the product is placed in the cabinet or removed for use. It takes about 2 seconds to read 100 tags. RFID is a great solution for high-value items or items requiring individual track, trace, and control. This is not the same technology that you might use for asset tracking, which requires significant infrastructure investment, such as wiring buildings, but instead, it uses the unique, inexpensive, passive RFID tagging with active readers, such as the cabinets or handheld devices. RFID-enabled processes allow for accurate inventory management without the need for counting. It's important that the tags interface with your hospital information system, MMIS, and charge capture system. RFID technology provides real-time inventory tracking for ultimate visibility and control. It will virtually eliminate counting errors. You should see an increased clinician satisfaction by harmonizing with existing workflows. There are reduced safety risks associated with expired and obsolete products and product recalls. There should be reduced costs associated with eliminating surplus inventory storage and improving charge capture, increasing revenue. Overall, with the right system, it will enable material staff to make more informed decisions, empowering them. As an industry, we've been focused on inventory management solutions that support better supply chain practices. Emory St. Joseph's implemented an RFID solution, effectively managing more than $2.5 million in inventory, monitoring over 2,000 SKUs in 7 cardiac catheterization labs and 3 electrophysiology labs. The approach is improving financial, clinical, and operational performance in many ways. Saving inventory costs. The RFID solution reduces and right-sizes on-hand inventory, setting accurate par levels based on real-time usage patterns. The approach also optimizes bulk buys to take advantage of cost savings without tying up cash on the shelves with unneeded products. And it eliminates overnight shipping due to stockouts. Maximizing revenue. Emory St. Joseph's captures all patient charges at the point of care and manages missing items daily to avoid lost charges. Automating inventory management. Now hospital staff can order products based on projected usage, decreasing shelf life and improving turn rates. The system monitors high-use products to avoid stockouts and low-use products to exchange them before expiration. Automated processes help prevent manual errors. Optimizing clinical workflow. From picking products to capturing usage to returning unused products to inventory, the RFID solution helps improve efficiency everywhere. Improving patient safety. Automated alerts notify staff of expiring and recalled products before they can be used with patients. Increased clinical satisfaction. Now there's greater product availability, so clinicians don't need to be concerned about stockouts. Emory St. Joe's in Atlanta has seen outstanding results. There was a 60% improvement in inventory turns and the elimination of premium freight costs. An over 80% reduction in expired and obsolete products through 100% tracking and control, along with the recovery of $300,000 in product costs lost through previous processes. This is a good summary. Tube and kanban, as mentioned before, is best for your low-cost supplies like gauze and bandages. No need for cycle counts, no need for clinician time spent coding items in and out of a closed cabinetry system. To the right, for the high-cost physician preference items and implantables, the greatest level of tracking should be utilized, which would be our RFID technology. Using the 80-20 rule, we would expect that your lower-end supplies make up about 80% of your SKUs, but 20% of your cost. Likewise, the higher value items make up about 80% of costs, but only 20% of your SKUs. In conclusion, there's a lot of opportunity in supply chain to improve financial performance, advance safety and quality of patient care, and stay ahead of healthcare reform. Standards continue to increase. Technology and the ability to access meaningful data is available, and now's the time to drive more value from our supply chains. I will leave you with one final thought. Raise your expectations. If you have any questions about what I covered today, I encourage you to reach out to us. We would love the opportunity to connect with you and further explore how you can implement some of these cost-eliminating principles within your organization. Thank you for your time.